Causes. Growth depends on a complex range of factors, including genetic makeup, nutrition, and hormonal influences. The most common cause of short stature is having parents whose height is below average, but around 5% of children with short stature have a medical condition. Conditions that can underlie short stature include undernutrition due to a disease or lack of nutrients, hypothyroidism leading to a lack of growth hormone, a tumor in the pituitary gland, diseases of the lungs, heart, kidneys, liver, or gastrointestinal tract, conditions that affect the production of collagen and other proteins, some chronic diseases such as celiac disease and other inflammatory disorders, mitochondrial disease, which can affect the body in different ways, including growth. Sometimes an injury to the head during childhood can lead to reduced growth. A lack of growth hormone can also lead to delayed or absent sexual development. Rheumatologic diseases such as linked to short stature. This may happen because of the disease or as a result of glucocorticoid treatment, which can affect the release of growth hormone. Disproportionate short stature or DSS usually stems from a genetic mutation that affects the development of bone and cartilage and undermines physical growth. The parents may not have short stature, but they may pass on a condition that is linked to disproportionate short stature, such as achondroplasia, spondyloepiphyseal dysplasia disease or SED. Types. There are different types and causes of short stature or restricted growth, and they will present differently. Because the range of conditions is so broad, restricted growth can be classified in various ways. One categorization is variant restricted growth, proportionate short stature PSS, disproportionate short stature DSS. Each of these categories includes a number of types and causes of short stature. Variant restricted growth. Sometimes a person is small but otherwise healthy. This can be referred to as variant restricted growth. It may happen for genetic or hormonal reasons. If the parents are also small, this can be called familial short stature or FSS. If it stems from a hormonal issue, it is a constitutional delay in growth and adolescence or CDGA. The limbs and the head develop in proportion with the spine, and the individual is otherwise healthy. Growth happens throughout the body, so the legs, for example, are in proportion with the spine. In most cases, the individual's parents are also small, but sometimes small stature happens because the body does not produce enough growth hormone, or the body does not process growth hormone properly. This is known as growth hormone insensitivity. Hypothyroidism can lead to low hormone production. Growth hormone treatment during childhood may help. Proportionate short stature or PSS. Sometimes overall growth is restricted, but the person's body is in proportion and the individual has a related health problem. This is known as proportionate short stature or PSS. If the individual is heavy for their height, this can suggest a hormone problem. The problem could be hypothyroidism, excess glucocorticoid production, or too little growth hormone. A person who is small and their weight is low for their height may be experiencing malnutrition, or they may have a disorder that leads to malabsorption. Whatever the underlying reason, if it affects overall growth, it may impact development in at least one body system, so treatment is needed. During adulthood, a person with this type of restricted growth is more likely to experience osteoporosis, cardiovascular problems, reduced muscle strength. Rarely, there may be cognitive problems or problems with thinking. This depends on the cause of the short stature. Disproportionate short stature (DSS). Disproportionate short stature is linked to a genetic mutation. The parents are usually of average height. As with other types of short stature, a range underlying causes is possible. An individual with disproportionate short stature will be small in height, and they will have other unusual physical features. This may be visible at birth, or they may develop in time as the infant develops. Most individuals will have an average sized trunk and short limbs, but some people may have a very short trunk and shortened but proportionately large limbs. Head size may be disproportionately large. Intelligence of cognitive abilities are unlikely to be affected unless a person has hydrocephalus or too much fluid around the brain. Achondroplasia underlies around 70% of cases of disproportionate short stature. It affects around 1 in 15,000 to 1 in 40,000 people. Features include an average sized trunk, short limbs, especially the upper arms and legs, short fingers, possibly with a wide space between the middle and ring fingers, limited mobility in the elbows, a large head with a prominent forehead and flattened bridge of the nose, bowed legs, lordosis, a progressive development of a swayed lower back, average adult height of 4 feet or 122 centimeter. Hypochondroplasia is a mild form of achondroplasia. It may be difficult to differentiate between familial short stature and achondroplasia. Achondroplasia and hypochondroplasia result from a genetic mutation. Genetic conditions such as Turner syndrome, Down syndrome, or Prader-Willi syndrome are also linked to disproportionate short stature. Treatment. Treatment will depend on the cause of the short stature. If there are signs of malnutrition, the child may need nutritional supplements or treatment for a bowel disorder or other condition that is preventing them from absorbing nutrients. If growth is restricted or delayed because of a hormonal problem, growth hormone treatment may be necessary. Pediatric hormone treatment. In children who produce too little growth hormone, a daily injection of hormone treatment may stimulate physical growth later in life. Medications such as somatropin may eventually add 4 inches or 10 centimeters to adult height. Adult hormone treatment. Somatropin, also known as recombinant growth hormone, might be recommended for people who have a severe growth hormone deficiency, experience impaired quality of life, are already receiving treatment for another pituitary hormone deficiency. Adult patients generally self-administer daily with an injection. Adverse effects of somatropin include headache, muscle pain, edema or fluid retention, problems with eyesight, joint pain, vomiting and nausea. The patient may receive treatment to control chronic conditions such as heart disease, lung disease and arthritis. Treatment for disproportionate short stature. As disproportionate short stature often stems from a genetic disorder, treatment focuses mainly on the complications. Some patients with very short legs may undergo leg lengthening. The leg bone is broken and then fixed into a special frame. The frame is adjusted daily to lengthen the bone. This does not always work. It takes a long time and there is a risk of complications including pain, the bone forming badly or at an inappropriate rate, infection, deep vein thrombosis, a blood clot in a vein. Other possible surgical treatments include use of growth plates, where metal staples are inserted into the ends of long bones where growth takes place to help bones grow in the right direction. Inserting staples or rods to help the spine form the right shape. Increasing the size of the opening in the bones of the spine to reduce pressure on the spinal cord. Regular monitoring can reduce the risk of complications. Complications. A person with disproportionate short stature may experience a number of complications. This include arthritis later in life, delayed mobility development, dental problems, bowed legs, hearing problems and otitis media, hydrocephalus or too much fluid in the brain cavities, hunching of the back, limb problems, swelling of the back, narrowing of the channel in the lower spine during adulthood and other spine problem, sleep apnea, weight gain, speech and language problems. Individuals with proportionate short stature or PSS may have poorly developed organs and pregnancy complications such as respiratory problems. Delivery will normally be by cesarean section. Most people with short stature will have a normal life expectancy, and 90% of children who are small for their age at 2 years will catch up by adulthood. The 10% who do not catch up are likely to have a condition such as fetal alcohol, Prader-Willi or Down syndrome. A person with achondroplasia can also expect a normal lifespan. However, some serious conditions that are linked to some cases of short stature can be fatal.